Hello, my name is Dr. Paul Chervy. I'm a haematologist in the UK. Today I'd like to talk to you about a Goldilocks problem we're having with lymphoma diagnosis. Lymphomas are common, they account for maybe 10% of all malignancies. And depending on your point of view, your perspective, biopsy samples are either too big or too small in a significant number of cases. The histopathologists prefer whole node excision. That means taking out a whole lump the size of a cherry or even the size of an apple so that it can be examined under the microscope. This is a big procedure for the patient. It generally involves a general anesthetic. The expenses and the delays and the risks associated with that are considerable. So, in order to shortcut the problem, many hospitals and services have reverted to standard soft tissue biopsy techniques, namely core needle biopsy, to solve the lymphoma diagnosis problem. The problem with this approach is that it yields a very small sample size, perhaps 10 to 20 millimeters long and only 1 millimeter wide. And this, in a substantial number of cases, is going to result in inadequate labeled diagnosis, where a repeat sample is requested, and also there are difficulties in subclassifying different types of lymphoma, particularly Hodgkin's and follicular lymphomas, and also there's insufficient leftover material which is required nowadays for further specialist investigation. So either too much or too little. So in order to get over this problem, we've devised a new mouse trap, which we've called the paste biopsy device. And here you can see it here. It's a simple intermediate solution whereby by using blades which are projected one over another, we can obtain a significantly larger sample size and thus satisfy the histopathologists with a good sample and satisfy the patients because they can avoid the need for a general anesthetic, the delays and the risks that incurs. The paste biopsy device consists of ergonomically designed handle which encases a spring-activated mechanism. This is controlled by pulling and pushing the green trigger, which in turn activates the precision-engineered blades which are manufactured in Switzerland. The inner stylet is ultra-sharp for penetrating the tissue, and behind this lies the biopsy bed. There is an outer rectangular profile cannula which cuts the biopsy. This will result in a very large specimen size of 4 millimeters wide by 20 by 1 millimeter deep. The samples are very cleanly cut. The mechanism is very straightforward. Simply pull back to the 10 or to the 20 millimeter position. Then advance the green trigger into the lump of interest. Fire the biopsy. Remove the device. Then expose the sample by further pulling and pushing on the trigger, and decant into the transport medium. This is a photo of the samples obtained following processing. Have a look at these samples carefully. For the patients, you get a benefit in that there's no general anesthetic and you get an accelerated diagnosis. For histopathologists, they're happy because they get a broad panoramic view of tissue with lots of leftover tissue. Interventional radiologists are presented with a familiar semi-automatic mechanism designed for single use, sterile and with centimeter markings. And for hematologists and oncologists, it means an earlier start for chemotherapy, enables us to beat those cancer targets, and gives us better outcomes, especially for our patients. They're the real beneficiaries. Using an earlier prototype, we've already tested the PACE biopsy device on 14 lymphoma patients and have obtained very good results in terms of sample size and in terms of side effect profile. If you're a hematologist or an oncologist or an interventional radiologist managing these patients, whether in the UK or in Europe, we'd love to hear from you. In return for free sample, we would like your feedback as to the effectiveness of the device in your clinic, its usefulness, any comments about its safety profile or suggestions for improving the device. You can contact me at the email address below. Just one last thing. Remember, next time you see a new high-grade lymphoma patient, according to some registry data, 25% risk the patient will die before effective chemotherapy is started. Now, a lot of that is due to patient frailty, but a substantial number, I bet, is due to delay in diagnosis. And maybe this is where we can help one another.